Hello everyone, my name is Dr. Brendon Neuen. Thank you for this tremendous honour in being invited to speak to you at the Pakistan Society of Nephrology International Conference. I wish I could be there in person, but I look forward to a stimulating discussion. And today I'm going to be talking to you on clinical guidance in using SGLT2 inhibitors in patients with type 2 diabetes and chronic kidney disease. These are my relevant disclosures. So for over 2 decades now, renin-angiotensin system blockade with ACE inhibitors and ARBs have been recommended to reduce the progression of chronic kidney disease in people with type 2 diabetes and people with albuminuric non-diabetic kidney disease. And this is based largely on data from the IDNT and RENAL trials, which demonstrated that the angiotensin receptor blockers reduce the risk of kidney outcomes in people with albuminuric chronic kidney disease and type 2 diabetes, with risk reductions in the order of 15 to 20%. Now, with the advent of SGLT2 inhibitors, we've got really robust data here that demonstrates that SGLT2 inhibitors reduce the risk of kidney failure requiring dialysis by 35%. And this is on top of ACE inhibitors and ARBs. And you can see the 2 kidney outcome trials, Credence and DAPA-CKD, in the bottom of half of screen, demonstrating really clear reductions in the risk of patient-level outcomes in kidney failure. When we break down that effect on kidney failure, looking at different levels of starting GFR at the initiation of therapy, what you can see here is that the relative benefits of SGLT2 inhibitors are consistent regardless of your starting GFR, all the way down to a GFR of 30. Similarly, when we look at the data for relative benefits of SGLT2 inhibitors in terms of kidney protection across different levels of albuminuria, what you can see here is that the benefits for kidney protection are similar regardless of whether you've got macroalbuminuria, microalbuminuria, or normoalbuminuria. But whilst the relative effects on kidney disease progression are similar across different levels of eGFR and UACR, the absolute risk reductions are greatest in people with advanced CKD. These are data from the pooled Canvas and Credence programs trials, enrolling almost 15,000 participants, and this is for the outcome, a broad cardiorenal outcome of myocardial infarction, stroke, heart failure, kidney failure, and death. And what you can see here is that for every 1,000 patients treated over 2.5 years, for people with a GFR less than 45, you'd prevent 115 events, translating to a number needed to treat of 8.7. Similarly, for people with the highest levels of albuminuria, the numbers needed to treat to prevent one cardiorenal event over 2.5 years is only 6.3. Really demonstrating that the patients who benefit most are the people who we're likely to see in nephrology clinics, people with low GFR and high UACR. It's on this basis that the KDIGO guidelines now recommends that SGLT2 inhibitors are offered first-line therapy alongside RAS blockade for kidney protection, and are also recommended as first-line alongside metformin for glucose lowering. And this is really reflected in all major guidelines around the world now, the American guidelines, the European guidelines. And the basis of this is that SGLT2 inhibitors need to be initiated regardless of metformin use and regardless of baseline HbA1c, because we know these drugs have very powerful effects on preventing kidney disease progression and cardiovascular events, particularly heart failure. How about in people with non-diabetic kidney disease? Well, the DAPA-CKD trial enrolled approximately 4,000 people, a third of whom had non-diabetic kidney disease, so a mixture of IgA nephropathy, hypertensive nephrosclerosis, and other glomerular diseases. And what the trial demonstrated was that regardless of whether you had diabetes or not, the benefits for kidney protection and cardiovascular events, as well as mortality, were similar. So these drugs are not really considered glucose lowering agents anymore, but primarily cardiac and kidney protective therapies. In DAPA-CKD, when the treatment effect is broken down by the type of kidney disease, whether that's a glomerular nephritis, hypertensive nephrosclerosis, or diabetic kidney disease, you can see on the left-hand side of panel the relative treatment effects as well as the absolute effects on the right-hand side are similar regardless of what the cause of your underlying CKD is. So these therapies are likely to have very broad impacts and quite a lot of ability for implementation in our CKD clinics. Interestingly, when DAPA-CKD was conducted, it recruited about 250 people with IgA nephropathy. Now, when you look at the effect of dapagliflozin on kidney disease progression in IgA nephropathy, doubling of 50% decline in GFR, kidney failure, or death, what you can see is a very clear reduction in the risk of kidney disease progression, requiring dialysis in people with IgA nephropathy. And this is regardless of, and this is for the primary endpoint and also the renal specific endpoint. So now patients with IgA nephropathy can be offered dapagliflozin to prevent kidney disease progression. So this is all well and good, and you may have seen a lot of this data presented at other conferences, but how can we implement this in routine practice for the benefit of our patients and to do so safely? So what I'd like to emphasize to you today is that these drugs are thought to protect the kidneys by reducing intraglomerular pressure. What that manifests clinically is an acute dip in GFR at the start of therapy, and this occurs within hours of taking the drug. What you can see, however, is after following an initial dip in GFR, there's stabilization in kidney function over time in the top panel. But when you look at an individual level, you can see that there is a lot of variation across different patients. Some people will experience an acute increase, some will experience an acute decrease, but about half will experience a GFR decrease. What does that mean in terms of safety and efficacy? Well, we looked at that question in the Credence trial, and what you can see on the left-hand side of panel are the canagliflozin treated participants, and on the right-hand side, placebo-treated participants, and you can look at their GFR over time according to their initial eGFR dip. And what you can see on the left is, regardless of whether you had an increase in GFR, a decrease in GFR, or no change in the first few weeks of therapy, your benefits were the same and always better in the blue bars than the placebo-treated participants who lost more kidney function over time. So the benefits are similar regardless of that acute GFR dip or GFR change. How about safety? Now, we again looked at canagliflozin treated participants on the left and placebo treated participants on the right, and looked at the risk of adverse outcomes according to the GFR dip. What you can see on the left-hand side of the screen is there's no difference in safety outcomes for patients who experience an acute dip, an acute increase, or no change in GFR. And that is really reassuring for us as clinicians. When we stratify that acute change into more granular categories, what we can see is, if you look to the left-hand side of the screen, canagliflozin treated participants, you can see for those participants who had a greater than 30% dip in GFR, there might be an increased risk of renal-related adverse events. So my threshold for withdrawing or temporarily holding treatment is an acute GFR dip of greater than 30% with SGLT2 inhibitor therapy. This occurred very rarely in only 1% of cases, or less than 1% of cases in Credence, so is not a major cause for concern. So what do we need to know about the acute GFR dip? Well, this data gives us a lot of reassurance that in most patients we don't need early monitoring within 4 weeks, unless you've got concerns about volume depletion, they're taking high dose loop diuretics, or maybe in the elderly. And this is because the eGFR dip doesn't give us any prognostic information with regards to efficacy or safety. But temporary discontinuation may be considered if the acute dip is greater than 30%. So I often bring patients back at the 4-week mark just to check their labs. One of the early concerns of these therapies were that they might increase the risk of acute kidney injury, and what actually has been demonstrated is the opposite. When you look at the totality of the trials, there's a really striking effect in that SGLT2 inhibitors reduce the risk of acute kidney injury by about 25%, and that's a consistent effect across these trials. Whilst the exact mechanism is not yet known, we hypothesize that these drugs might reduce the susceptibility of the proximal tubule to volume and ischemic related insults, thereby protecting the kidney from acute kidney from these kinds of injuries, and that's because the proximal tubule is a workhorse for the kidney, and movement of sodium at the basolateral aspect is ATP dependent, and by reducing energy expenditure we might be improving oxygenation in the kidney. Unlike ACE inhibitors and ARBs, SGLT2 inhibitors reduce the risk of hyperkalemia by about 15 to 20%. What you can see here is data demonstrated from the Credence trial, which showed that canagliflozin reduced the risk of serious hyperkalemia defined as potassium of greater than 6 by 23%, with a consistent effect regardless of your baseline potassium. In fact, we've looked at the data across the SGLT2 inhibitor trials, and this is a consistent effect across the class of agents, with about a 15% risk reduction in serious hyperkalemia. And this is important because it might enable us to better use renin-angiotensin system blockade and mineralocorticoid receptor antagonists in people with CKD and heart failure. Reassuringly, these drugs do not cause hypoglycemia. Now, here is a forest plot looking at the totality of the evidence over 50,000 participants. What you can see here is that severe hypoglycemia occurs less commonly with SGLT2 inhibitors than other glucose-lowering agents, and as a result there's little need to adjust background therapy. One of the characteristic findings of this class of drug is that their effect on glucose diminishes as GFR falls. So in patients that we're likely to see in nephrology clinics, the glucose lowering effect is actually pretty negligible. But in people with normal kidney function at GFR greater than 60, it might be reasonable to adjust their background therapy to assist in the facilitation of adding an SGLT2 inhibitor. So how can we do that? I often consult with my endocrinology colleagues, but in patients with normal kidney function who are taking a sulfonylurea, often what I'll do is check their glucose control, and if it's at target, then consider stopping the sulfonylurea or adjusting their insulin to facilitate the addition of an SGLT2 inhibitor. I'd like to emphasize that in most cases in CKD, this is not necessary because SGLT2 inhibitors have little effect on glucose lowering at lower GFR. How about concomitant diuretics? Well, we know that across the trials, there was a pretty low risk of volume depletion overall. But what you can do is, in people with normal blood pressure who are on a loop diuretic, I will often reduce the loop diuretic by 50% to reduce that risk of volume depletion. Although this wasn't done in the trials per se, I think this is a not unreasonable way to manage our patients to reduce that risk. And this is what is done in many clinics around the world and is personally my own practice. Generally, I don't need to adjust thiazide diuretics in general, but this is just something to consider. We do know that these drugs increase the risk of mycotic genital infections by about 3 times, mainly in people with poorly controlled diabetes, and so it's important to counsel our patients about the risk of thrush and other mycotic genital infections. The vast majority of these infections are pretty manageable with either no change or temporarily holding treatment, and we've looked at this data in the Credence trial. One of the most common misconceptions about SGLT2 inhibitors is that they increase the risk of UTIs. And if you look at all the trials, almost all of them have demonstrated either no or negligible effect on UTIs. There's a marginal effect that can be detected once you pool over 50,000 people, but this effect is very, very small, and so a previous urinary tract infection should not be considered as a contraindication to SGLT2 inhibitor therapy. So what are the ways to practically mitigate these risks of potential adverse effects? Well, I always emphasize people the importance of personal hygiene to reduce that risk of thrush and mycotic infections. And importantly, although I haven't spoken too much about it today because it's very rare, temporarily holding these treatments after or in the context of major surgery, and if patients aren't eating and drinking, is important to reduce the risk of ketoacidosis, which is mainly seen in people with long-standing type 2 diabetes who are on high doses of insulin. So where to next with SGLT2 inhibitors? Well, we have the DAPA-CKD and Credence trials, which enrolled people with albuminuria chronic kidney disease. And we have the EMPA-Kidney trial, which is soon to be completed and hopefully reported in the next 12 to 18 months. And that recruited people with an even lower GFR, a starting GFR down to 20 mils per minute with a mean GFR of 37 mils per minute, and many people with no albuminuria or very little albuminuria. And that's going to give us a lot more information on non-diabetic kidney disease and normoalbuminuric chronic kidney disease, with many glomerular diseases being recruited, about 800 people with IgA nephropathy. And this is going to be really crucial and to our understanding of how these agents can benefit our patients with kidney disease. Where to next? Well, I think, as I mentioned, SGLT2 inhibitors are being studied in people down to a starting GFR of 20 mils per minute. There are also now trials in kidney transplant recipients and possibly even patients receiving dialysis, whom, whilst they might not benefit from kidney disease protection, might benefit from cardiovascular protection, given that these drugs have many ways that they're working that might be independent of their primary site of action. We now have finerenone, which is a non-steroidal MRA, as well as GLP-1 receptor agonists, and how we use all these therapies in combination remains to be determined, and trials that testing combination therapy are going to be really crucial to understanding what standard of care is going to be in the coming years. And finally, whilst it's great to have this evidence from clinical trials, there is the challenge of access and implementation, and it's upon all of us to try and get as many patients who'd benefit onto treatment as much as possible to reduce the risk of adverse outcomes and improve quality of life and extend life. So in summary, SGLT2 inhibitors should be routinely offered to people with albuminuric chronic kidney disease, regardless of the presence or absence of diabetes, and that's because they can safely reduce the risk of kidney failure and cardiovascular events. These drugs are easy to use, and this is underscored by the fact that they're once-a-day dosing, they don't require dose titration, they don't have significant drug-drug interactions. In fact, they reduce the risk of acute kidney injury and reduce the risk of hyperkalemia, unlike renin-angiotensin system blockade. So they really should be used as much as possible in our patients with CKD. There's an acute dip in eGFR that should be anticipated, but doesn't confer any risk of adverse outcomes. And for the most instances, adjustment to background glucose lowering therapy is generally not needed in CKD. The risk of volume depletion is generally low, but reduction in loop diuretic dose might be considered in people who are already euvolemic and at their blood pressure target. Thank you very much for your attention today, and I'm very happy to take any questions.